appreciate that. And so while we don't have our photos up on this particular slide or in the beginning, we do have those photos at the end. We didn't want to scare you away, but our photos were on the invitations to this particular webinar. So let me summarize this agenda here for you really quick before I dive in. In the beginning, the first third, I'm going to be talking about some critical issues around procuring pharmacy benefits, managing pharmacy benefits that is very important to plan sponsors. In the middle of the webinar, Day is going to provide you with some solutions to those issues, particularly around your contract or your arrangement with your PBM. And then I'm going to wrap up, and Day, I hope I'm not stealing your thunder here. I'm going to wrap up with what are the results that you could hope to achieve when those issues are recognized, when those issues are then solved. What does the PBM performance then look like? So stick around. We don't anticipate being more than 30 minutes, so stick around. We've got some really exciting stuff for you. If you have questions, two ways to get those questions to us. You can send them via the chat interface there on your GoToTraining control panel. Also, there's an option to raise your hand. Everyone's muted for obvious reasons. If you raise your hand, we will unmute you, and then we can have a dialogue back and forth around your question. So let's get to it. So whenever we approach a potential client or one approaches us and we ask the problem, we ask the question, what's your most pressing problem around the pharmacy benefit? Inevitably, it comes back 9 times out of 10, something around price, concern around price, or maybe a concern around a lack of transparency. And so there's no easy way to solve that pricing problem without eliminating information asymmetry. So it's not, or another way to put, in layman's terms, information asymmetry means information failure. When one party has access to a bunch of information and it doesn't share all the information that it has access to, and those two parties are sitting at the negotiating table, the party with that information who doesn't share it is engaging in information asymmetry or information failure. PBMs intentionally withhold information so that they make it difficult to ascertain what they're being paid. What are their management or service fees? We're going to talk about that here a little bit more in depth here in a second. So that leads me to the status quo. Plan sponsors enter into an agreement with a PBM that calls for an artificially too low admin fee. Hypothetical. Artificially too low admin fee is anything below, let's call it $6 per paid claim. But we're seeing admin fees today that hover around 50 cents per paid claim, $1 per paid claim, and in some cases, there's no admin fee charge. When that happens, whether it's no admin fee charge or whether it's $2 per claim, 50 cents per claim, that essentially gives the PBM the green light to augment their management fee in the back end. That augmentation, so think about this for a second. The only transparent form of revenue that a PBM generates and earns and puts in its bank account is the admin fee. It can be accounted for relatively easy, but it's the other 3 buckets that are a lot more difficult. And we're going to talk about how to get into those here in a bit, with the biggest bucket being manufacturer revenue in terms of how the PBM is generating its management fee. The spread is a markup either from the retail claim or the mail order claim. A spread is not a mistake. A spread is not a billing error. A spread is intentional. It is a way a PBM could generate its management fee. And so a spread, and let's be clear, is the difference between what a PBM's client, a third-party payer, is being billed and what the pharmacy is being reimbursed by that same PBM. Any difference is what's referred to as a spread. Big case about 2 years ago, the state of Ohio decided it was going to look into its PBM's cost performance, except it was going to do it a little bit different this time. It was going to eliminate information asymmetry. And so what they decided to start looking at, instead of just rebates, which I'm going to talk about here in a second, instead of just looking at rebate guarantees and discount guarantees, you know, at the point of sale in a retail pharmacy, they wanted to look at how much money the PBM was making off the deal. Now, if Greg were here today, he would tell you to a woman or to a man that it's here. He said, we're not saying this is too high. We're saying this is information we've never had before. He would tell you it's information they never requested, and more importantly, they never demanded before. And when they got it and saw how much money the PBMs were keeping, they terminated those contracts essentially on the spot. So the state of Ohio was only looking at spreads in that particular report. By the way, that report is online, it's public information, you can go out and get it. But in that report, they mentioned they hadn't even looked at rebates. They were only evaluating spreads. They had not looked at rebates yet. And so the importance here is, as an employer, as a third-party payer, you face a double whammy when it comes to rebates. Part of it may be kept by the PBM, and then the other part is that they're only offered on the most expensive drugs, with those drugs, 90% of them having lower cost therapeutic alternatives available to them. That's why it is so very, very important, right? It's very smart people, big companies, and all I hear them talk about are the rebates. All I hear them talk about is the rebates. It's so very, very important because those branded drugs have lower cost therapeutic alternatives, primarily rebates, that you take advantage of generics wherever possible. The generic dispense rate, the percent of drugs being dispensed in totality, what percent are generics? It should be 90% or above. It should be 90% or above. If you're 81, 82%, for every 1% you increase GDR, you're going to cut your costs in the neighborhood of 1.5% to 2%. That's a lot. That is a lot. And so just a couple considerations around rebates here is, plan sponsors believe, you believe, your clients believe you're getting 90% of the rebates back, right? But are there other fees that are being paid by the manufacturer to the PBM? Those are rebates. They've just been renamed. Have those been addressed in the contract? Dave's going to talk about that here in a second. And then more importantly, I'm coming back to information. Does the employer have the right information to be making these decisions, to be making the determination that we're getting 90% back? We're trusting the word of the PBM. We're getting 90% of all available rebates coming back from the manufacturer. This is an example of information success, the opposite of information asymmetry. As a fiduciary PBM, and any PBM that is calling itself transparent, at a minimum, when it pays its clients rebates, should be providing a receipt in conjunction with those paid rebates. That receipt is what's called a remittance form. And in that document, every claim that was eligible for rebate is included in that document. Additionally, the amount of rebates that were being paid is included in that document at the NDC level, at the claim level. I go back then to PBMs intentionally making it difficult to ascertain their management fees. I'm going to allow you yourself to speculate on why a PBM would push back on sharing this level of information with its clients. And just for the record here, some of this information is redacted, plan ID, RX number, all that good stuff. That's private information, but it is populated when we share this document uh, with our client. So how is the term rebate defined in the contract? Again, this is an issue. My friend Day is going to provide the solution. And so in this example, rebate means rebates collected by the PBM as a GPO for a client from various pharmaceutical companies that are attributable to prescriptions dispensed to members, but excludes rebates paid specific to the utilization of specialty drugs. What? 50% in the slide I shared with you, the status quo, 50% of a PBM's profit comes from the manufacturer. In other words, the rebates, the bulk of that is specialty drugs on both the retail, the pharmacy side and the medical side. It is not uncommon for plan sponsors to enter into a contract where they forego rebates on specialty drugs. You can't do that. Also, what if the rebate is paid on a basis that is not attributable to the client's drug purchases? And see, you see in contracts a lot, um, uh, rebates paid based upon attributable to the utilization of the client. That's how it'll be worded. Well, not all rebates that are paid are based upon utilization. Some of them are paid based upon market share. And that's an arrangement between the PBM and the manufacturer, or the aggregator and the manufacturer. I'm going to show you a neat slide here towards the end when we wrap up. So I'm bringing this home and I'm going to pass this along today. This is a lawsuit that was filed about 3 years ago between Express Scripts and Kaleo. It's public information. Express Scripts sued this specialty drug manufacturer for rebates it believed it was owed and wasn't paid. I happen to believe that they were owed the rebates. But my point is this. If you don't believe me, believe the information that I'm sharing with you that is public information. Go out on the web. The formulary rebates, Express Scripts engage in negotiations with Kaleo. Based upon those negotiations, the formulary rebates it was owed by month are here. But it also engaged in negotiations for a different type of rebate, or a relabeled rebate, administrative fees, which is different than the administrative fee I talked about earlier. They're different. That administrative fee is for claims adjudication, customer service, account management. This is purely between the PBM and the manufacturer. And it can be a little confusing. These rebates, which you deserve or your client deserves, dwarf these rebates. And if it's not addressed in the contract, guess what? PBM's management fee. That's where it goes. Now, you may think that number to be insignificant. I can promise you it is not. We're going to talk about that here in a second. So I'm going to turn it over now to Day, and he is going to share with you some solutions around specifically the contract language, the PBM contract language.
Thanks, Tyrone. Hopefully everybody can see my screen. All right,
Yeah,
so.
we can see it. It's just the presenter's view.
Okay, great. So again, thanks, Tyrone. I echo his comments about the importance of having a well-defined rebates term in the contract. It will dictate the amount of rebates that are relayed to the plan sponsors. Typical example of vague and ambiguous rebates definition reads as follows. Rebates mean retrospective formulary rebates that are paid to the PBM pursuant to the terms of a formulary rebate contract negotiated independently by PBM and directly attributed to the utilization of certain covered drugs by members. A better definition should have specified rebate types such as manufacturer revenue, financial payments, financial incentives, credits, discounts, market share rebates that the PBM and its rebate aggregators received from the manufacturers. Well-defined rebates are mutually beneficial to the plan sponsor and to the PBM because it will not only reduce the total drug spend, but also mitigate the risk of contract dispute down the road. One of the key contract terms is the definition of brand and generic drugs. Hatchman-Wax Act is a law that passed back in, I believe, 1984, and that created the generic drug industry as we know it today in the United States. However, it does not define brand or generic drug. Why is that important? Because the definition of brand and generic drug is a key component of reducing a plan-sponsored drug spend, and it is dictated by the contract terms negotiated between plan sponsor and the PBM. Now, brand and generic definition of those key terms are inherently related to the pricing guarantees. I cannot stress enough how important it is to have a tight definition of brand versus generic drug in the contract. The definition of generic drug on this slide read as follows. The term generic drug shall mean a multi-source drug set forth in a nationally recognized source as reasonably determined by the PBM that is available in sufficient supply from multiple FDA-approved generic manufacturers of such drugs. This is very, very loosely defined term for a few reasons. First, it does not specify the pricing source. Second, the PBM has absolute discretion to use whatever pricing source it deems as reasonable. Third, it does not define what sufficient supply is. And lastly, it suggests that single source generics are not categorized as generic drugs, which will lead to many, many, many issues. So hypothetically, an unscrupulous PBM can use the loosely defined generic drug definition that we just reviewed to their advantage in various ways. One classic driver of drug spend of a plan sponsor is spread on generic drugs. So PBM can pay a network pharmacy X dollar on a generic drug prescription, but charge plan sponsors significantly more than what it actually paid to the pharmacy by utilizing two different pricing sources. PBM, unfortunately, they can make a call for argument that the definition allows the PBM to utilize pricing source reasonably determined by the PBM. So vaguely defined brand and generic drugs can be abused by PBMs to fit their needs, that is, pricing guarantees. Many PBM contracts that I reviewed allow the PBM to classify drugs for one purpose in one way and for another purpose in another way. To expand on the example that we just discussed, PBM can charge brand drug pricing to the plan sponsor while paying the pharmacy generic drug reimbursement on that single source generic claim. And again, PBM can use different pricing benchmark to create or to generate bigger spreads for themselves. It can also impact the generic substitution rate and the other generic pricing guarantees, such as generic effective rate. So in the past few years, I think beginning in 2018, independent pharmacies have been hit with post-sale recoupment involving generic effective rate, GER, which is a contractual rate set forth by major PBMs for the reimbursement of generic claims. The scope and extent of generic claims are, dictated by the contract language and can be different from widely accepted definition of generic claims. The theory behind the GER was to enforce stability around the reimbursement that pharmacies receive in a given calendar year. How does that impact the plan sponsors? Well, PBM's contract with its network pharmacies, or PSAOs, may exclude single source generics from the GER, while it may include single source generics in their contract with plan sponsors. So in other words, PBMs can recoup millions of dollars from their network pharmacies, many of whom are independent pharmacies, using GER calculation while inflating its generic substitution performance guarantee to a plan sponsor by including single source generic in the generic drug category. Not only that, inevitably, such practice drives independent pharmacy out of business, and it only bolsters the vertical integration in the pharmacy benefit management industry. Of course, PBMs can categorize brand drugs as generic drugs and not pass the rebates it received from the manufacturer to the plan sponsors. Needless to say, scope of PBM services is extremely important. Generally, PBM services include pharmacy network contracting, pharmacy claims processing, mail and specialty drug pharmacies, formulary and rebate administration. I've seen contracts wherein the scope of PBM service was not defined and the plan sponsor did not know whether their PBM conducted routine audits to maintain integrity of their pharmacy network. Assuming that plan sponsor was a Medicare Part D sponsor, then that sponsor, under the federal law, has the obligation to monitor the pharmacies for fraud, waste, and abuse. Not only that, it is plausible that the PBM could have audited, investigated pharmacy claims and recouped overpayments from the pharmacy. And the plan sponsors, should have received the post point of sale recoupment, and it should have been reported in the DI report submitted to the CMS by the plan sponsor. Moreover, having a clear scope of PBM service allows plan sponsors to carve out services such as drug utilization management that can be delegated to third parties other than the PBM itself. Why? Because PBMs may likely have conflict. The largest insurance, PBMs, and specialty pharmacies have now combined into vertically integrated organizations. As you all may know, United Healthcare owns Optum and its specialty pharmacy, Brioba. Cigna, Express Scripts, and its specialty pharmacy, Accredo. It should be of no dispute that conflict exists when vertically integrated PBM performs drug utilization review of its own prescription claims. So it is important that plan sponsors understand and document and formalize the scope of PBM services. Turning to rebate audits. For plan sponsors, in order to monitor and review PBM performance, you have to conduct full audit. Unfortunately, it is often the case that the plan sponsor audit rights are limited. How? It limits the actual number of audits that can be performed in a given time period, and it limits the actual review period, meaning the claim submitted within 1 year or 2 years can only be reviewed annually. Okay, now it further limits rebate audits by only allowing the rebate audit to be conducted by an auditor that is approved by the PBM. Even then, the auditor is only provided information and documents that are deemed necessary by the PBM to conduct the rebate audit. In extreme cases that I've seen, the PBM will not allow the auditor to review the rebate contract between PBM and the manufacturer. Not only that, the auditor's notes are taken during the audit are subject to PBM's review and kept confidential. So I want to reiterate Tyrone's comments about demanding radical transparency and demanding the remittance report at NDC claim level as part of the regular reports that plan sponsors should receive from the PBM. Another trend that I've noticed is that PBMs charge plan sponsors for providing documents or information that are necessary for the plan sponsor to conduct an audit. It shouldn't be that way. Plan sponsors should demand PBM to provide documents as part of their PBM services. Also, PBMs can, and at least one of the major PBMs, national PBMs, charge audit fees, percentage-based audit fees to pharmacies. And at the same time, that PBM charges certain fees, audit fees, to the plan sponsors. So in other words, PBMs can double dip by charging audit fees to the plan sponsor as well as to the pharmacy when it comes to pharmacy audits. So again, audit rights and the plan sponsor's right to have certain documents should be formalized as part of the contract. At the end of the day, between plan sponsors and PBM, the governing document is the pharmacy benefit management agreement. Now, usually PBMs limit the audit to a certain window of periods, and if plan sponsor misses that window, then plan sponsors loses its ability to audit and check performance of the PBM. That said, through litigation and discovery, plan sponsors can retrieve information and documents from PBMs outside of the limited audit window. More importantly, plan sponsors must ensure that PBMs delegate certain functions such as rebate administration and collection to third parties such as rebate aggregators, but only after obtaining plan sponsors' authorization. And plan sponsors should receive rebates received by the PBM and rebate aggregator. This is very, very important. We recently obtained a $6 million settlement against the PBM owned by a publicly traded company on behalf of a Medicare Part D sponsor. In that case, what we discovered was shocking. We found out that the PBM used, unbeknownst to the plan sponsor, its own rebate aggregator, which kept substantial sums of rebates, and the PBM was not accurately reporting and returning rebates to the plan sponsors. Nowadays, PBMs have its own rebate aggregators. Optum has Coalition for Advanced Pharmacy Services. Caremark launched Zinc in the past year or so, and Express Script, they set up offshore rebate aggregator called Ascent Health. So how can a plan sponsor have a radically transparent, fully passed through contract? it starts with a solid RFP process. Plan sponsors must establish clear terms to vet out PBMs that are not willing to provide radical transparency. So first step is to require consulting firms to have a skilled staff with extensive PBM knowledge. And of course, the consulting firm and its staff should be fiduciary of the plan sponsor and not incentivized by the PBM. Second, plan sponsors should dictate the terms of the contract, removing all the loopholes, including but not limited to rebate aggregators, vaguely defined rebate provision, ambiguous brand and generic definition, as well as pricing guarantees. Third, plan sponsors should only seek information that can be quantifiable and verifiable from the PBMs. And also make sure that PBMs understand if there's any material change to the contract, they're going to be eliminated. Fourth, negotiate with PBMs. Plan sponsors should demand clear terms and better prices. Never split the difference. Fifth, make PBMs compete against themselves and make them commit to the contract terms, okay? And lastly, conduct interview and presentation, but based on data. It's not a beauty contest. Plan sponsors must be involved in all phases of the RFP, and they should not delegate decision-making to the consultant, broker, or the PBM in order to have a firm and solid RFP. So with that said, let me turn it over to Tyrone.
Hey, Day, so I just gotta, I'm listening to you, and I hope the folks that are here today are paying attention and taking notes. That last piece you said about never splitting the difference. I just had a conversation with a potential client who was a student of ours, who initially had negotiated very strong terms, but the PBM came back and said, well, hey, if we provide this, then we've got to reduce the GER guarantee that we were offering, and they did it. And they did it, not understanding that by reducing the GER, I think they dropped it to 75%, minus 75% off of AWP for generics. I about fell out of my chair, because that PBM just on generics alone is essentially printing money. Printing money. So I hope everyone's listening. Okay, Dave, if you could, all right. If you could, if you've passed the presentation over to me.
Yeah, I did. Are you not getting that notice?
Yeah, give me a second here. I'll just do it myself. Yeah, it's not popping up for me. Here we go. All right, so just wrapping up here. And so the issues I've identified, the solutions that Dave provided, what does this all mean? What are we asking you to do when you combine those two aspects? What we're asking you to do, like the state of Ohio, is to start evaluating how much money the PBM is going to make off of each individual deal it enters into. And the only way you can do that and come reasonably close is to get access to the information. So the earnings after cash disbursements is a fancy way of saying the PBM's fee. What are they charging to manage your pharmacy benefit, to manage your client's pharmacy benefit? Everything in green lands in the PBM's bank account. The PBM, if it is not fiduciary, is trying its best to hold on to as much as what's landed in their bank account as possible. And that means that it is going to charge its clients more for the same drug it paid a pharmacy. That means it is going to keep a percent or share of rebate dollars or manufacturer revenue that it never disclosed to its clients that it was going to keep and pass back the rest. Those are examples of cash disbursements. Whatever is left over is what the PBM is paying itself. For goodness sakes, folks, is it too much to ask if you hire a plumber how much you have to pay them when they're done with unclogging your toilets? Is it too much to ask if you need an oil change to know what it's going to cost and to get a receipt for that oil change? We're not doing that with PBMs. We are just saying, charge us whatever you want to charge us. The new path says this: taking Dave's advice, in terms of what he said was another insight was the PBM contract is the primary driver of transparency. It is the primary driver of getting to lowest net costs. It is the primary driver behind not overpaying or whether you're going to overpay. The new path says this: the PBM makes money one way, and it is through a radically transparent admin fee. And the trade-off now is that the PBM forgoes contractually all other means of generating revenue for itself. And so I say that to say this, and I'm wrapping up here. I got 2 minutes. I'm often asked, Tyrone, what's the difference between a fiduciary PBM and a non-fiduciary PBM? You know what I used to say? I used to say, well, the fiduciary PBM is obligated contractually to put its clients first. It always has to act in its client's best interest, first and foremost. That means if it could do something right by the client and that PBM doesn't make any money by taking the right action, then that's what it has to do. All of that is true. But in our world, what it really means is, because plan sponsors are eyes wide open when rebates go up from the previous contract, when discounts get bigger from the previous contract, eyes are wide open. And so they're swooned by optics. You're swooned by optics. Not necessarily getting the lowest net cost, but just the optics. So let me tell you what the optics mean. The difference between a fiduciary PBM and a non-fiduciary PBM is what happens after your plan goes live. That's the big difference. As a fiduciary PBM, I can't tell you how many times I've thought about what my competitors do and how much money we could be making if we did what they do, but don't want to do that. I'd rather do the right thing and make less money than do the wrong thing and make more money. In this example slide here, this is the negotiating that they talked about between the PBM and the manufacturer. All of these rebates here are negotiated between the PBM and the manufacturer. And then what happens is all of these get here to the PBM, but no matter what you believe, the PBM then is keeping everything here and only passing back this. And that's if you're lucky, you get 100% of formulary rebates. That's the difference. What happens after the plan goes live? These are the types of results that a plan sponsor could hope and expect to achieve when the PBM doesn't do this, when it doesn't take spreads. Even as a fiduciary PBM, we negotiate a minimum rebate. We negotiate generic and brand discount guarantees. And then you know what happens when we outperform them? Because every PBM does. Or if we don't outperform them and we fall short, most PBMs negotiate the minimum that you can claw back, right, in the event that they fall short somewhere. But 9 times out of 10, we exceed the minimum. As a fiduciary PBM, we give back what we exceed. That's the difference. And the numbers add up fast. I talked about the PBM's management fee. One could reasonably assume that Prime Therapeutics gets a better discount from pharmacies, PSAOs, chains, independents than we do. They're much larger. One could also reasonably assume that they get better rebates from manufacturers than we do because they're larger, more buying power. So the myth that larger PBMs are going to lead to lower costs for the client is just, it's a myth. Because what Prime has done, if our all-in is $23.12 and Prime's is $57.88, and that case study is a part of this webinar, right? So make sure you pull that down and read it. We get more in depth. There's testimonials in there. Make sure you pull it, download it, and read it. But their management fee is the difference between $57.88 and $23.12. Their management fee is essentially $35. Folks, that's more than the drugs cost. Our all-in cost includes our fee. It's net of rebates. It includes claims costs. And they were $35. They were charging more to be their PBM than the drugs actually cost. That is the result of when you win a radically transparent PBM deal. All right, that is our time today. I think I may see a couple questions in here. I'm going to see what we have here. The question is, how much time should you allow for a thorough RxRP to have effective valuation? That is, if you get good data. Whoo, that's a very good question, Frank. It depends on the sophistication level of the client and their needs. So for an example, if it is a TPA and they're doing an RFP for a PBM, they want to have as kind of their primary PBM vendor, you're looking at 18 months from when you should start. 18 to 24 months, you should be starting that process. if you are a self-funded employer, maybe 100 to up to 10,000 lives, you could probably go as far as maybe 15,000, 6 months minimum. 6 months minimum. Because you want to leave that time. Listen, PBMs, they know you've got a drop dead date. And so the non-fiduciary PBMs love it when you wait and put the contract at the back of the RFP instead of at the front. It's the most important piece, but far too often it gets left until the end, until the front. Right? So at a minimum 6 months, but you want to leave your, and so when you start that RFP and you start getting that information in, those responses, a part of that response should be the PBM's contract. And you should be negotiating as soon as you get that contract, that negotiating and winning concessions should be a part of the RFP from day one. You're welcome, Frank. Okay, it doesn't look like we have any more questions. So listen, this is our first one. We plan to be doing a lot more of these. So we're going to work out the kinks, but stay tuned. We'll be doing a lot more of these. Everyone be safe, and then we'll talk soon. Thank you.